Dear colleagues, my name is Dr. Klimenko. I'm medical resident at St. Vincent Medical Center, and for me, it's a great pleasure today to discuss about COVID-19 treatment guidelines for hospitalized patients at St. Vincent Medical Center. As per data from Johns Hopkins University, more than 113 million people worldwide are infected with COVID-19. In the United States, we have up to 30 million of infected people and approximately 0.5 million deaths. Overall mortality risk is from 0.5 to 1%. If compared to influenza, it's 0.1%. So with COVID-19 pneumonia, mortality risk from 5 to 10 times higher. Hospitalized patient mortality in New York City initially was up to 25 to 28% in the beginning of the pandemic, and then decreased to 7-8% by the summer 2020. As per data from China, ICU mortality for COVID-19 RDS patients who ever received mechanical ventilation range between 65 to up to 94%. Again, Johns Hopkins University reports that approximately 80% of COVID-19 patients will have non-severe disease, and they will not require any additional treatment, only symptomatic. And 20% will have moderate to severe infection, 15% will require hospitalization, and 5% will require ICU admission. Current criteria for hospitalization based on National Institute of Health guidelines, there are oxygen saturation below 94% on a room air, respiratory rate more than 30 minutes, fraction of arterial oxygen to fraction of inhaled oxygen below 300, which represent ARDS, lung infiltrates on the chest X-ray or CT or computer tomography more than 50%, also altered mental status. At St. Vincent Medical Center, we pay high attention for patients who are 65 years and older with multiple comorbidities, who also have lymphopenia or thrombocytopenia with moderate symptoms of COVID-19 and infiltrates on the chest X-ray. Because these patients, this population, they're in a higher risk of deterioration at home. Currently, all patients with COVID-19 or it calls patient under investigation, for whom we don't have positive COVID-19 test, but we have high suspicion. For it, they're placed in negative pressure rooms, especially who will require BiPAP or high flow oxygen supplementation. In the top of the pandemic, all the hospitals were closed for visitors. They have strict non-visitor policy. And we, all the medical staff, we receive donning and doffing PPE training. PPE stands for personal protective equipment, and N95 fitting test, which you currently see here on this picture. So they place a special bag on your head and put aerosol inside. And without N95, you can feel sour or sweet taste. Then N95 placed, and if it fit for you, if it's working, you should not feel any taste. And here is outside of each room, we have this device when you can place pressure that you want, humidity and temperature. Here you can see our ICU. So in ICU, we have 2 patients per nurse, in PCU 3 to 4 patients, and on the regular medical floor, it's up to 6 patients per the nurse. Here you can see nurse station, and she could constantly monitoring patients. This is our working station called Computer on Wheels or COWS. Every day in the morning we have rounds next to the room. We examine the patient, then discuss with multidisciplinary team and put in orders into this computer. In the hallway, you can see red and blue boxes. Red box, for patient with cardiac arrest, you can find inside everything necessary to run the code. And blue box, it's for patients who require immediate intubation. Basic labs which we are doing on each admission with COVID-19 pneumonia. It's basically CBC, metabolic panel, and inflammatory markers like CRP, LDH, ferritin, D-dimer, and procalcitonin. Also, each patient will have EKG and troponin levels. This is the most important trials which were used treating COVID-19 patients. One of the most important is recovery group, and all the links you can see in the bottom for them. Recovery platform has multiple branches, and they study multiple medications. Next one, it's adaptive COVID-19 treatment trial, OACTT1, Solidarity trial, Impacta, REMAP-CAP, BLAZE-1, BLAZE-4 trial, RECOV-2, and Preserva. All the trials we'll discuss further. And next, you will hear a presentation of my colleague, Dr. Armando Vera. Thank you so much for your attention.
Well, good. Hi, everybody. My name is Dr. Vera, and I am one of the second-year residents at St. Vincent's Medical Center. And first of all, I would like to say thank you very much to Dr. Manko for inviting me to this talk, and hopefully I can share a little bit of my experience while treating patients with COVID-19. And I would like to start with the prone positioning of a patient with severe ARDS, which is a very well-known complication of severe COVID-19. And the PROSEVA trial, it actually means prone positioning in severe ARDS. And the question was, does this prone positioning actually helps to reduce all-cause mortality versus patients that were not prone or in a supine position? And they studied 466 ARDS patients with a PF ratio of 150 and lower, which by definition meets the severe ARDS. And of course, they would have to have FiO2 about 60 and PF about 5 when the patient was ventilated. This study is done after the Ards study in 2000, and also the low fluid volume, which is the FACT trial in 2006, and the therapeutic paralysis, which is accuracies, but all of them by itself reduce mortality. But the question was if the prone position can actually help. These patients have to be prone no longer than 36 hours after being intubated. And the early application was for a long period of time, or 16 hours. And then they started to see if there was a mortality benefit in this patient. Important to know is that this trial actually incorporates the low tidal volume ventilation strategy and also paralysis, which suggested that this patient might benefit also from early pronation as well. The criticism that this study received is that we don't know if patients have less experience doing this prone positioning, more rates of complication, and this was a highly selected patient population. But when you have these patients, you compare the 28-day mortality, we know that there's about a 16% reduction in patients that were prone versus the ones that were supine. And we know that the confidence interval, it's support these results. And they also showed a 90-day mortality benefits in patients with prone versus supine positioning. We're now going to talk about one of the most or widely used therapies, which is the remdesivir. Remdesivir is actually derived from a trial that is called the ACT-1 trial. And there is, the question was that if remdesivir could reduce the time to recovery. We know that it doesn't reduce the mortality of severe ARDS due to COVID-19, but this is a therapy that was originally developed for Ebola. And this therapy actually, it's a prodrug of the adenosine analog that will inhibit the RNA-dependent RNA polymerase in the virus. This was a double-blind, placebo-controlled trial, which the primary outcome was the time to recovery. It did show that these patients recovered 4 days than when patients were compared to placebo, 4 days before, sorry. But it did not show any significant benefit with the mortality as well. One other thing about this treatment is we only have it IV, and it's every 24 hours. You have to give a loading dose of 200 milligrams. Then you can give it for either 2 to 5 days. This is right now, but when they did this study, it was up to 10 days. And when we were considering these patients for the criteria, patients did have to have a GFR of above 30, could not be pregnant or breastfeeding, and neither cirrhosis or any elevated LFTs 5 times over the upper limit. And there's another therapy that is called an antibody-based therapy, which is basically the convalescent plasma. This therapy was thought that by promoting passive treatment with the antibodies, we could treat the patients more effectively, but we failed to do that. There was a randomized trials for convalescent plasma done by the Mayo Clinic for severe pneumonia, and 228 patients received the convalescent plasma and 100 received the placebo. 30-day mortality was not different between the two groups, and there were some complications related to the product transfusion, like volume overload. So the benefit didn't outweigh the risk for receiving this treatment. So typically in our hospital, we don't use it as frequently. We use it in highly selective candidates that we think that they're gonna benefit. Like, for example, patients who are young, healthy, and are in the first stage, the inflammatory phase. Then we have an antibody-based therapy, which we try to neutralize the antibodies against the COVID-19 or the SARS-CoV as protein. And we use it bamlanivimab, cardassiminab, and indaminimab. And the inclusion criteria is patients who are admitted for a non-COVID diagnosis, weighted more than 40 kilos, and have a documented positive result for SARS-CoV-19 within the last 10 days. We typically give it to all patients above 65 years of age, and patients who are less than 65 years but have many comorbidities like diabetes, BMI more than 35, chronic lung heart conditions, and CKD stage 3, or other immunosuppressive conditions. And patients with medical-related technological dependence, for example, tracheostomy, gastrostomy, or positive pressure ventilation, not related to COVID-19. This is sometimes we saw patients that just come for infusions and receive one-time dose, and most of the patients that were analyzed did not develop severe COVID-19. The results of this trial are yet to be published, but it's something to take under consideration. And well, thank you very much for having me, and hopefully you enjoyed this presentation.
Hello, my name is Natalia Dyatlova, and I work as a resident physician in one of the hospitals of Illinois, Northwestern McHenry Hospital. And I'm going to continue this presentation from this slide. And here I'm going to talk about immunosuppressive and anti-inflammatory therapy, which we basically use in late phase of COVID-19 infection or for people with more severe form of COVID-19 infection. And I'm talking about patients who require oxygen supplementation or mechanical ventilation. Corticosteroids, methylprednisolone, hydrocortisone, dexamethasone, those are commonly used, but the most common would be dexamethasone. As studies show that this medication administered in 6 milligrams once a day for 10 days reduced 28-day mortality among patients receiving invasive mechanical ventilation and those receiving oxygen without mechanical ventilation. This medication didn't show any benefit for patients with light form of COVID-19 infection who do not require any oxygen supplementation. And I'm going to talk about interleukin-6 inhibitor, tocilizumab. This medication we administer in a dose of 8 milligrams per kilogram once. For that medication, the patient has to meet criteria and certain indications. So first of all, there would be an increase in oxygen requirements within 48 hours of steroid therapy. And also if C-reactive protein continues to rise despite the management. This medication reduces the risk of death among hospitalized patients with severe COVID-19 infection. It also shortens the time until discharge and need for mechanical ventilation. Studies have shown, for instance, 29% of patients died in the tocilizumab group within 28 days compared to 33% patients in the usual care group. It basically means that for every 25 patients treated with tocilizumab, 1 additional life would be saved. Among patients not on invasive mechanical ventilation, tocilizumab significantly reduced the chance of progressing to invasive mechanical ventilation or death from 38% to 33%, and those numbers were statistically significant. Thank you very much.
Hi, I'm Dr. Mopuru, one of the colleagues of Dr. Klimenko. Today I'll be talking about the anticoagulation part in COVID-19 infected patients. So it's definitely a controversial topic, and as we all know that COVID infection increases the risk of venous thromboembolism and arterial thromboembolism. So there were many studies which were done to detect the prevalence of venous thromboembolism, and some of the results were it showed 9% in cohorts of mixed patients, 23.2% in ICU patients, 25.2% in series of systematically screened patients for venous thromboembolism, and 12.7% in series of symptomatic patients were detected with venous thromboembolism. And the frequency rates of overall acute thrombotic events, including the acute coronary syndrome, stroke, or any other form of arterial thromboembolism, with 3.9%. The outcomes were measured in a hospital, and that's Tonji Hospital. The study was done in 183 patients who were confirmed with COVID-19 pneumonia. It's a retrospective study which actually showed 71.4% of non-survivors showed direct intravascular coagulation, and 0.6% of survivors showed DIC. So on June 2nd, 2020, CHEST has released a couple of guidelines helping to guide the treatment of venous thromboembolism in patients with COVID-19. And some of the statements are anticoagulation thromboprophylaxis is definitely recommended in acutely ill patients and critically ill patients. In acutely ill patients, it is recommended to use low molecular weight heparin like fondaparinux or unfractionated heparin over a direct oral anticoagulant. In critically ill patients, it is also recommended to use low molecular weight heparin or unfractionated heparin over fondaparinux or a direct oral anticoagulant. So direct oral anticoagulant is not recommended to use in acutely and critically ill patients due to high risk of rapid clinical deterioration, high likelihood of drug-drug interaction, and high likelihood of acute kidney injury. Use of standard dose of anticoagulation for venous thromboprophylaxis is recommended over full dose of anticoagulation, as there is lack of studies which shows that full dose of anticoagulation is superior when compared to the prophylactic dose. Inpatient thromboembolic prophylaxis is recommended for patients rather than patients getting outpatient thromboembolic prophylaxis. In critically or acutely ill patients, the use of antiplatelet agent for venous thromboembolism prophylaxis is not recommended. In critically ill patients, the expert panel suggested not to use routine ultrasound screening for the detection of asymptomatic DVTs. In acutely and critically ill patients with active bleeding or an increased risk of bleeding, mechanical thromboprophylaxis is suggested. So some of the common methods of mechanical thromboprophylaxis we used in our hospital are intermittent pneumatic compressions, graded compression stockings, and venous foot pumps. So these help to improve the blood circulation in the lower extremities and help to prevent the blood clots. Thank you so much for letting us share our COVID-19 guidelines, which we practice in our hospital. Hopefully this will help the doctors and the medical staff and the healthcare providers who are watching this video in Ukraine and for better COVID-19 management. Thank you.